remotely and virtually. It's nice to see everyone. The topic of the conversation today ended up being very timely with everything that's going on in this unusual world that we live in now. And I'm going to talk about the intersection of consumerism and healthcare. I am just going to kind of break the seal here real quick and say COVID, just to get it out in the air. No pun intended there. But this talk is not going to focus on COVID. I'll talk about it in the context of consumerism and healthcare towards the end of the conversation. As Brad mentioned, we actually have a webinar from one of our physicians that is going to be open to the public for individual kind of lay people to ask questions of a concierge physician about COVID. It's really difficult to get your hands on all the right information. And so we set up a webinar this morning that'll be on Tuesday next week, and I'll share the details as we get into this. But you look at the norms that we have today are completely upside down. And I want to kind of start with, what we have for norms in healthcare. Healthcare is such a unique market that is the things we've accepted as consumers as just kind of normal course of business in healthcare. We don't accept anywhere else in our lives. One of my examples I like to use is we've just kind of accepted it's very normal for hospitals to name themselves on a religious faith, right? We go to Presbyterian Hospital, we go to Catholic Health West, we go to Methodist Hospital, and it's totally normal. But if you apply that to any other business, like have you ever gone to a Catholic Wendy's or gone to a Presbyterian pharmacy? And of course the answer is no. And if I'm Presbyterian, can I be seen at the Methodist hospital? Is that okay? But it's just kind of one of those somewhat comical things that we've accepted is very normal, that there are those faith-based organization names tied to our hospitals. I had a conversation with a good friend of mine a couple weeks ago, back when humans were allowed to get together and meet. We were at a great restaurant here in Charlotte called Comet Grill. Those of you that have been there, one of the better burgers in town, you should check them out whenever we're allowed to be out in public again, or take to go from them right now. And I'll call my friend Brett because that's what his name is. And Brett had asked me, what do you think is the next revolution in healthcare? So he's not in the healthcare space, but some of his customers happen to be in healthcare. And I very quickly said back to him, I said, it's consumerism. And I didn't yell it at him. That's not why the font's bigger. It's just to kind of draw attention to it. But consumerism is really what I think is going to be the next revolution. And he came back, he kind of looked at me with a very puzzled look. And he says, why is consumerism going to be the next big thing? I said, well, let's just take an example of how consumerism works in a different industry. So let's look at car shopping. But let's look at if it were a healthcare type of scenario. So if you were going into shop for a car, but you treated it the same way you treated healthcare, here's basically what would happen, right? Is you would identify that you needed some mode of transportation. You would walk onto the lot of a car dealership. You would walk up to the car salesperson and you would say, I need an automobile. I don't know much about automobiles at all. I have no idea what kind of automobile I need. I don't know what kind of automobiles you sell. I don't know how expensive they are. And oh, by the way, most of it's not my money anyway, so it doesn't really matter. And hopefully you're starting to get this image that the car salesperson now is salivating, right? I mean, they can't wait. They're just kind of looking at their friends like, man, I got a heater here. I can't wait to sell this. I'm going to oversell this person everything I possibly can. And as I'm going through telling my friend Brett this story, he's like, that's interesting. Bring it back into to healthcare for me. I said, well, imagine if you needed to get your hip replaced. And he goes, actually, I got my hip replaced 2 years ago. I said, well, that's perfect. I said, so, what kind of research did you do on, your surgeon before you went and had the procedure? He goes, well, none. What kind of research did you do on the hip that they actually put in your body before they did it? Well, none. So he just kind of accepted that the everything that was going to be done right, and it kind of is what it is. And I was like, and how much did you pay? And he said, well, at the end of the day, it ended up being $90,000 for the whole soup to nuts for the whole procedure. And obviously not all of it came out of his own pocket, but effectively he had bought a Range Rover. Brett had bought a Range Rover, had it inserted inside of his body from a price point perspective, and did no legwork on it at all. And as you start to look at how we pay for healthcare, and I'll talk about that example here a little bit more in a minute, we look at how the risk starts to shift. And we've seen where the insurance companies have taken on the risk with HMOs back in the 80s. We started to see the health systems take on the risk with accountable care organizations in the 2000s. And now we start to see the shift into more high deductible health plans where we as consumers are taking on the risk for paying for all of the healthcare that we have. And I think as consumers start to be on the hook for more financials, we're going to demand that there's more opportunity to shop the healthcare that we're actually consuming and absolutely paying for as well. And so we all, you look at some of these norms, and we all know that healthcare has some of its idiosyncrasies, and we all know that it's broken. It's actually the one thing we all can completely agree upon is, in this 2020 election, there's not a single candidate that's going to have this sign, right, posted in your yard. Whatever your candidate's name is, 2020, healthcare is perfectly fine. No one's saying that. We all know that it needs to be fixed, that it is broken. And there's a number of opportunities for us to remedy that. And as consumers get more involved, I think consumers are going to be the ones that really drive a lot of the shift and the changes that we really need to see. So let's take another example of how we pay for healthcare, and let's use now a restaurant example. Right. So my favorite restaurant in Charlotte is the Custom Shop. I was heartbroken the other day when I called to get takeout from them, and they've closed temporarily. But I encourage you to go on to Custom Shop and buy a gift card. It's an absolutely great place for date night with your significant other, and a tremendous restaurant, great people, great food, and a great environment. So let's take an example with Custom Shop, right? So you go sit at Custom Shop, you make a reservation, go have dinner, sit down, order food, order a bottle of wine, server takes care of you, bartender takes care of you, chef cooks your food, you have an amazing experience, and you're done eating. So you get up and walk out. You just get up and leave. You haven't paid at all, right? And so a month later, the Custom Shop sends you an invoice for your meal, right? And you didn't know what the prices were because there were no prices on the menu for anything. And you've now been invoiced by Custom Shop to pay for dinner. And then, so you pay that invoice, fine, happy to pay for the food. A week later, you get another invoice from your server. Well, your server was an independent contractor. She's going to send you another bill, right, for her services. And you have to pay for her service plus tip her out. And I know, by the way, the bartender, has to charge you now for the bottles of wine that you had, plus for for their service, because they're also an independent contractor and it's a completely separate service. And in fact, this scenario plays out all the time in healthcare. With my dermatologist, every time I call it my weight loss plan when I go to see them, because they always take giant chunks out of me. I'm blessed with my German Irish skin that I have. So I pay for my visit at my dermatologist, and then they send off to a lab all of the samples that they had. And so I get a bill from the dermatologist, I get a bill from the lab, and I have to pay for all these things completely separately. So if we were to accept that as a norm that we have accepted in healthcare, and we would accept that in restaurants, the world just seems to completely turn upside down, even more so than it is right now. So there's, again, examples of norms that are totally bizarre in healthcare that we've accepted as consumers. Let's stick on this model though of how we pay for our healthcare, and let's use car insurance as an example. And I think this will get to the root and really get us to where I think there's some immediate activation for us as consumers to get more involved in trying to drive the future of where this consumerism really intersects with healthcare. So let's take car insurance and say we all have, those of us that have cars, we all know it's mandatory to have car insurance, and car insurance pays for accidents when we have them, right? It's liability insurance. Well, does car insurance also cover your oil changes or your gas fill-ups? And hopefully that's a little bit comical to you because, of course, in no way, shape, or form does it ever do that. And if it did, it would be, car insurance would be dramatically more expensive. It'd be much more inefficient, and it would be a very unsatisfying experience for everyone involved. Well, take that model and say, look at health insurance. And in fact, we now have a single health insurance plan by and large, and it covers your major medical events, right? You have to have a surgery, you get in a car accident and have to end up in an ICU. It covers your preventative care visits, and it covers your acute episodic care, right? Where you may have a flu-like illness, for example. And we wonder why health insurance is so wildly expensive, inefficient, and very unsatisfying. And it's no wonder that the insurance plan that we've built around healthcare really needs to be decoupled. And we need to separate out these things, the preventive care, acute episodic care, into completely different buckets and envision the way that we pay for that completely differently. And so this is really where the notion of membership-based medicine comes into play. Membership-based medicine has a number of different names, oftentimes called concierge medicine, direct primary care. I will just call it MBM because it's a mouthful to say otherwise. But effectively what MBM is where I really think this is the intersection of consumerism and healthcare. And what it entails is, as a patient, we pay a fixed monthly or annual fee to a primary care physician. All right, so this is the doc that's taking care of my diabetes, my annual physical, when I come down with an illness or sickness and I need to be seen on an acute outpatient basis, but I'm paying them a fixed monthly or annual fee. For that, I get a set volume of services. The models can vary a little bit in terms of what's included in those services, and the annual prices can vary quite wildly as well. When you look at some of the practices that are can be as low as $100 a month I'm paying that physician, and others range upwards of $40,000 a year, depending on the type of model, the provider that you're getting access to. How they bill your insurance also varies wildly by practice. Some of them will in fact bill insurance for any additional costs that are incurred if you have to have some type of chest x-ray done or additional testing, lab testing done. Some of the practices will bill your insurance, others will not do that. But this is really where you start to see this complete intersection of consumerism and healthcare, and it's actually a win-win scenario across the board because it's a better place for the physicians and the consumers as well. Sorry, I didn't want that to pop up just yet. So from a physician's perspective, they get to manage fewer patients. They have more volume and revenue stability, and COVID-19 is a perfect illustration of that actually being the case, where many of these primary care physicians that are in what I'll call a traditional reimbursement model, where they actually have to have people coming through the door, patients coming through the door all the time, because that's the only way that they get paid, are unfortunately in a position where they're laying off staff. I talked to one of our Rome physicians in Indianapolis right before this call, and he talked to one of a primary care physician who is in traditional medicine, and they're laying off 8 of their nurses right now because they don't have the volume. They don't have money to be able to keep their doors open. And meanwhile, Matt, the physician I was talking to, is they've already have access to all of their money that they're getting because it's not based on actually seeing patients in real time in the office. So these physicians have more time to spend with each patient. They've got a better work-life balance. And then from a consumer perspective as well, COVID is the perfect illustration of this entire scenario, where if you're in a traditional reimbursement model, the physicians in primary care are seeing between 2,000 and 3,000 patients in their panel. In an MBM model, they're seeing between 20 and 400 roughly. And as I was talking to that physician in Indianapolis earlier today, he's actually made phone calls to every single one of their patients to check in on them. He's not waiting for them to call in and say that they're sick. He's actively reaching out. And so it's that type of touch and that experience and that relationship you build with your physician that is much greater. in this COVID world, if you have to go in for an episodic visit, you're going to run into much smaller waiting rooms in an MBM type model, and much shorter lines, if there are any line at all, to get access to those physicians. So I know that folks probably, given that I'm an infectious diseases pharmacist by background, wanted to talk about COVID. I'm happy to take a couple questions if we have them towards the end. But what I've actually set up is one of our concierge physicians that's here in Charlotte, Dr. Phil Lackey at Signature Healthcare, agreed to do a free webinar that's open to the public. So an opportunity as a kind of for lay people to ask questions of a concierge physician around COVID is a free webinar that we set up. It's Tuesday the 31st from 7 to 8 Eastern. You can see the registration link there, and I'll be sure to share that with Brad as well, so he can send that to the group. Just an opportunity to have an open dialogue and conversation. It's so difficult to get access to legitimate, reliable data right now around COVID, and I thought this would be a great opportunity to get you some exposure to what a concierge physician is able to do as well. So now the opportunity to talk about Rome. So those MBM practices are exactly the audience that we help. So we're helping to unite them and help their practices succeed at the end of the day. Rome has around 100 member practices globally. Most of those are here in the United States, but we do have practices in Hong Kong, in London, and a couple in Canada as well that we're growing out. But the way that we help these physician practices, these MBMs, succeed is by enhancing continuity of their exceptional care. So we do something we call travel reciprocity. So let's say you're established with Dr. Lackey here in Charlotte, but you happen to be in Seattle, and you have a healthcare issue that arises that you call Dr. Lackey as your physician, and you do a telemedicine visit, but Dr. Lackey decides that you need to be seen, right? I need somebody to do a chest x-ray. I need somebody to look at that central line that you have in. I need somebody to actually put hands on the knee injury you have, whatever that might be. Well, with Rome, the Rome physician in Seattle will treat you as if you're already an established patient in his or her practice. So that travel reciprocity gives you the ability, instead of going to an urgent care or an emergency room in those scenarios, you actually get to see another concierge or an MBM physician that will treat you as if you're already established. So we help them with that care continuity in that way. We also help these MBMs with reduced overhead cost. I see my Rome Senior Vice President of Strategy and Practice Cost Management on the webinar. Mary Stokas is on with us today. So Mary helps us with all of our supply chain opportunities, where we're able to save these practices money and all the stuff that they buy to keep their doors open and deliver exceptional care to their patients. So we're able to save them money by uniting their spend and convening them under the single Rome platform in order to get that done. We also help them get exposure to patients and attract new physicians as well. This webinar around COVID is just a great opportunity for us to do that with Signature to help them grow their top line revenue as well. But we are a tech-based company, so we have an IT platform that gives them the ability to connect and to collaborate and to work together. I'll share the slides out with Brad. I wanted to include just some success stories of how we've actually been able to help these practices. There's a few of them here that I'll let you guys read on your own at another time. But basically, helping them with the connectivity of the network, giving them a sense of community, enhancing practice visibility, and really the travel reciprocity are the types of things that we're doing to help these MBMs succeed, which, again, back to that intersection of consumerism and healthcare, regardless of what hat every one of us is wearing today, if you're in healthcare, you're not in healthcare, we're all consumers of healthcare, and demanding a better patient experience and engagement relationship with our physicians is something we all need to demand more of. The last thing I want to say before I close out and turn back to Brad, I'm happy to do a little bit of Q&A. We are a Charlotte-based business, and it has been very fulfilling to find a very comfortable home here in Charlotte. We feel that we've got access to absolutely amazing people, amazing resources, staff, people who are seasoned and experts in healthcare across the board in a number of different verticals. We've actually, the Some of the supply chain partnerships that we've made are through an organization that's also based here in Charlotte called Premier. And it's been just a great place that we found to be home for our tech-enabled healthcare business. And so I'm very proud to be the CEO of Rome, to be able to join you guys today remotely. We're proud to be one of the shining stars in Charlotte, and I've had this chance to share a little bit of our story with you, and it's nice to see all your faces. And Brad, I'll turn it back to you to see if there's any questions I can address.
Great. Thanks, Kat. Yeah, if anyone has any questions, feel free to turn on your mic, turn on your video. We'll just try to be respectful of one another. And if two people jump in at the same time, just try to work it out as best we can. So if anyone has any questions for Scott, feel free to jump in and ask.
Hey, Brad, there's some questions in chat.
Hey, Scott, thanks for meeting with us today. Quick question. Who is your target demographic, or the largest portion of your customer base? And then this still feels like a pretty boutique program for folks to get involved in. What is really preventing you guys from going full-blown mainstream and kind of taking this to the masses?
Yeah, both great questions. So our target demographic is anyone who's in a membership-based primary care physician practice. So those range from the individual physician who's out on his or her own, and some of them don't even have an executive assistant or admin at the front door. We've got one of our physicians in New York that runs out of an office building. He's got 24 patients and doesn't want any more. We also have a practice out in Silicon Valley out west that has 4 different locations, one in Silicon Valley, one in San Francisco, one in LA, and a New York office. And they've got, 2 dozen physicians that they work with. So our target demographic is anybody who's doing that membership-based medicine. As far as the boutique side of this, Rome was started in 2017, and we built up the network over the first 2 years, refined the IT platform and how we deliver that and bring that to the physicians to help them grow. We launched the supply chain solution in December last year, and we're able to bring Mary on with us full time in January. So we're still very much a startup company, and getting the financial model right to help us grow has been one of the hurdles we've been getting over. And we feel like we've started to turn that corner, and there's light at the end of the tunnel. But we're actually going out for a round of funding here next month to help us kind of put our model on steroids to help us grow to more of the masses.
Hey, Scott. It seems to me there's a lot of interest in the sector, and there's One Medical just went public. Obviously they are different in that they run the clinics, but there's also folks out there like MDVIP, which seems to be kind of similar in that they, help existing practices turn into concierge. I guess what is the difference in your model?
Yeah, a good question. There are a number of different models that can kind of fall into this MBM example. You mentioned One Medical. Charlotte actually has a company, HealthStat, that works in that same vertical and competes with One Medical, working with self-insured employers and doing direct primary care. HealthStat's a great organization that has clients in 33 states, and as I mentioned, headquartered here in Charlotte. So as it relates to competition for Rome, there are a couple of other companies that do things similar to what we do. We are specifically focused on being a curated physician group. So the physicians that we've pulled into to this point have only been identified by other physicians who are in the network, that they kind of align with the philosophies of how they're operating their practices and their businesses. So that curation is something that's definitely separated us. There are the number of practices who are in Rome that have been converted to this MBM model. 90+% of them have been at it for 5+ years. So as much as MBM is kind of a new vertical in healthcare, it is the group that we have with Rome are seasoned veterans in the model, and not people who are just kind of getting started. So that's something that separates us from some of the other folks. And at the end of the day, I have abundance mentality. It's how I carry myself throughout all aspects of my life. And I think it's really good for us to have competition in the space. If there was no one to play against our Charlotte Hornets, there would be no other teams, and that would be really boring. And here we are, nobody's playing any sports at all, and that's really boring. So thank you for the questions.
This is Laura. I've got a question. Can you hear me?
Yeah, hi, Laura.
Hi, Scott. I was wondering about the doctors and yours thoughts around who their target is in terms of consumers. It seems like seniors that are aging in place is a category of interest, but maybe affordability might be an issue. I just was wondering how they view the market and their attack.
Yeah, no, also a really good question. And it varies based on how they've established their practice, right? So let me go back just to showcase some of the differences here. So based on how they've established their practice, so some of these that are doing what we would call direct primary care are doing more of the affordability play to keep those annual premiums at a very affordable rate. In this MBM space, there's a very large misnomer that this is only for the ultra wealthy, and it's a kind of a luxury service. Where that might have been the case, 10 years ago, it is surely not the case now. And you're starting to see all aspects, all different walks of life have the ability to have a real relationship with their physician in the way that only the ultra elite and wealthy would have 10 years ago. So in terms of their ideal demographic, I think what they're really looking for is people who are, want to invest in their healthcare and are demanding a different experience. And times like COVID, I would love to get a phone call from my physician checking in just to make sure that I'm understanding everything that's going on and that I'm doing well. So they're looking for people who are have maybe a little bit of disposable income, but you're not looking at tens of thousands of dollars in every one of those scenarios. And they have seniors, they have families. There are a number of these that are family medicine practices where they take care of children as well in pediatrics. So it is really all walks of life that they're looking at for targets for their clientele and their patients.
Thanks.
Patrick, if you're on, we had a question from you in the chat if you want to ask Scott. I'll just read it from the chat. Scott, I don't know if you can see it, but who have you found as your primary customer demographic? How does MBM mesh with insurance programs and Medicaid/Medicare?
I think Patrick has already asked that question.
Yeah.
Oh, you did? Did I miss that?
Yeah.
Nope, my bad. Just trying to get everybody included. Did Joel get asked
That's
his
okay.
question?
Yeah, so I'm going through, so I got the chat pulled up now. How does your model differ from a VIP? We answered. Demographic. Question. Thank you, Eve, for the compliment. My buddy Joel. How do you look at referrals for, say, the total hip example you started with? Sounds like Rome is mostly PCP. What is your specialist solution? Joel also represents an excellent healthcare tech company here in Charlotte with Pure Surgery. So thank you for the question, Joel. We are, yes, based as primary care physicians, and our network really focuses on that primary care model for that patient service. And those are the practices that we're trying to support. The way that we've connected our network through specialists, and this has actually happened a couple times here, even over the last few weeks, where a patient happens to be established patient from Tampa, Florida, happened to be in New York and needed to have blood drawn. And so I don't have a network of specialists that do phlebotomy in New York, but I've reached out to my primary care physicians who are there and they had access to the great phlebotomy company, and one of them even opened up their doors to do the phlebotomy, the blood draw on their own. It's a very similar situation from West Palm Beach, where a patient had to have shoulder surgery, and they live in New York, but some are down in Florida, so they were established with their primary care doc in West Palm Beach, and they wanted to know, where's the best place to go to get my shoulder surgery done. And we reached out to the primary care, one of the primary care docs that was in New York, who made the recommendation to the physician they would go to for that surgery on their own in New York. So we really leveraged that primary care network to connect us in the local communities to those specialists at hand. But Joel, it's probably worthy of you and I having a conversation offline to see where we might be able to hitch our wagons together on that.
Thanks, Scott. Love to.
Anyone else have any questions for Scott? Cool.
You mentioned, Scott, this is great, by the way. Thanks again for this. Very good stuff. You mentioned that this is becoming more widely adopted and not just seen as a luxury good. Are you seeing it in any in older populations and the Medicare eligibles? Is it is there I guess what are the differences in the uptake in different demographics? What does that look like? And is there a more favorable demographic from an insurance perspective in the way that jives with reimbursement?
Yeah, excellent question. So a number of the physicians who are in the direct primary care model have actually opted out of Medicare. And so what that means to opt out of Medicare, if you at any point accept Medicare patients, there's very specific rules that you have to follow on how you're charging for services, how you're pricing services, and what your accessibility is. Whenever you're able to opt out of Medicare and say that I won't bill Medicare, you can have Medicare and come see me, but I'm not going to bill Medicare for you. You're welcome to try to recoup some of those costs after the fact on your own and submit receipts, but I'm not billing Medicare. When they opt out, it gives them the ability to work very differently. So a lot of those direct primary care are not trying to recruit Medicare or commercial insurance patients as a specific demographic. With some of the more concierge models that we get to, many of them will do that insurance billing and will look to recruit the Medicare populations. I don't have any specific statistics, Vince, unfortunately, to be able to share with you on how many of those patients are in fact Medicare patients, how many of them have commercial insurance that are engaged in an MBM type of setting. But if I'm able to procure some of that after the fact, I'm happy to share it with you either through Brad, or you and I can connect offline to share more of those details.
Thanks a lot.
Anyone else has any questions for Scott? Can maybe even tease a COVID question or two, since we've got a few minutes left.
Right.
So.
Hi, this is Beverly. I have a question for Scott.
Hey, Barbara.
Hey, how are you doing?
Good to hear your voice.
Good to hear you too. Thank you for the talk. And you may have addressed this, and I missed this in your presentation. As I'm listening to you and thinking about who your target consumer is, say, for example, you have somebody who has had traditional health insurance, is unsatisfied with it, and they want to explore something like you're talking about. Is it something that you would recommend, or do you provide services for someone, a consumer who is looking to approach this in a different way and look at your services in adjunct to like policies for emergency medicine, and approaching it differently and educating the consumer of how to do that and walk them through that decision making? That's one part of it. The other part of it is you're direct target? Is it the individual consumer, or are you also targeting employers? And then thirdly, having that conversation with consumers. A lot of the employees' income, well, not a lot of it, but 30% or less of it is part of benefits, and having that conversation with employers to look at it differently, giving the decision power back to the employee to say, we can add dollars into your salary and take away that net of benefits for you to go out and do something similar to what you are offering up, Scott.
Yeah. 3 great questions, Beverly. I'll take the second one, the third one, and then the first one. So our target market for Roamed is actually the physicians' practices themselves. So we are focused on, they are the ones that pay for our services, and we help them get connected to the travel reciprocity. We help them with control their bottom line expense, and we help them grow their top line revenues is basically the way that we operate. There are a number of our practices that have not gotten to this point yet, but are looking to Roam to be able to open up the next chapter of their practice in approaching employers and having the employer vertical be a way that they can basically be more efficient with their selling process, if you will, to attract one employer, and now I've got 2,000 covered lives. So there's so some of our practices are looking to do that, but that's a fairly well penetrated vertical with companies like we've already talked about on the call here with One Medical and HealthStat and others in that space. As it relates to so the consumer is not necessarily our focus. If there are folks who are here on the phone, I'm happy to have separate conversations with you. What I would encourage folks to do, regardless of the market that they're in, is when you identify a practice, many of these physicians, since they're so relationship based in the way that they function, will actually encourage you to set up a trial visit. Come in and actually do an interview and see if it's a good fit. And they'll walk through, show you around, give you a tour of the office, have you get the chance to meet the staff, sit down with the physician, and many of them will really encourage those preliminary visits before you agree. So think about this, and Beverly, your question actually gives me the opportunity to bring it back to consumerism in healthcare. As you're looking at cars, you're probably going to shop for a couple of different cars. You're going to go look at the Ford and the Chevy and the Buick. Well, in this scenario, I would encourage you to do the same. Go talk to 2 or 3 physicians, have those visits, and see which one feels like the right fit. You're going to have an actual relationship. This isn't just going to be a transactional, I see you once a year type of situation. And it's important you get the right fit for the right person.
Log off. They're just answering random questions now.
Somebody forgot to mute.
Yeah. Thanks, Scott.
You're welcome, Beverly.
Sweet. But yeah, I think that's we're about at time. So thanks everybody for joining. Thanks, Scott. Again, I can give him a virtual clap here and shout out. So yeah, it was super interesting. Really glad to have you. And if anyone has any questions for Scott offline, I'm sure feel free to email him. And if you're interested in his talk on his webinar on Tuesday, we'll send out the info and the link for that. In terms of next Tech Talks, our next one for April will be virtual as well. So I'll get that out to everybody Monday, and look forward to seeing you there again. And stay safe, everyone. And thanks again for joining.
Thanks so much, Brad. Take care, everyone.
See you guys.